Hello, my name's Cathleen. At the end of February 2020, my daughter Maggie caught strep throat. The meds seemed to work quickly. Day 3, she complained her ankles were stiff. This was nothing new. The next day, Saturday, February 29th, we headed to New York City. She seemed fine getting on the train in Trenton, but an hour and a half later at Penn Station in New York, she was walking like a 90-year-old and said everything hurt. We taxied to our hotel, and she crawled into bed before noon, and we stopped the antibiotics. She was sweating and seemed to have a high fever. By midnight, I was concerned, and I called to find a car service that could take us home in the morning. COVID was in New York City, and it didn't seem safe to take her to an urgent care or a nearby hospital. Sunday, we made it home and went to our local CHOP urgent care. They provided us with a new antibiotic and said it was probably serum sickness. Not doing any better the next day, Monday, we took her to our local ER, and after fluids and labs, they sent her home because she had perked up. Wednesday, she seemed worse, and the hospital called, asking us to come back due to contaminated labs. Labs showed a blood infection, and we were transported by ambulance to CHOP, as she seemed to be getting physically worse before our eyes. A rash, high fever, and barely moving and in pain, she looked wilted. Over the next week, CHOP doctors worked to get the infection under control and worked their way through a barrage of testing. Finally, it came down to cancer or arthritis. Once diagnosed as SJIA, it seemed a miracle that 6 hours after being given anakinra, she was able to walk to the cafeteria totally normal. After 17 days, she was released to home with monthly Alaris shots. At that moment, doctors thought a year of treatment was likely to bring on remission. We were not prepared for her SJIA journey. August 2020, she had her first MAS flare with her second over Thanksgiving. More steroids and more hospital time. In April 2021, she did 2 chemo treatments. No changes occurred other than some hair loss. Her doctor added tacrolimus, then switched to Jakafi. Both caused elevated kidney and liver labs. We started to talk about bone marrow transplant and completed genetic testing, including meetings with the BMT doctors. May 2021, she had another flare and was held captive to receive Gamifant treatments, as our insurance wasn't sure how to manage the drug and wouldn't allow outpatient treatment. 7 weeks later, she was home and feeling good. She was doing okay and continuing her monthly Alaris shots. We had canceled all of our summer plans. We were feeling good until January 2023. A year and a half later, she had a flare. We felt defeated. More steroids, more unknown. We added Jakafi again, that again caused elevated labs. Then there was talk of MAS 825 treatment, and her doctors did the legwork to get her included, and she started treatment in October 2023. A year later, and Maggie is doing okay on biweekly infusions. She currently has been fighting a spinal infection since February, but colds do not become fevers, rashes, or flare-ups. It's been a stressful journey, giving ourselves grace for disregarding her joint pain, complaints when she was younger. In the first two and a half years, Maggie gained 160 pounds from steroids, meds, and her mental health struggles. Middle school is tough enough, then adding COVID and a misunderstood autoimmune disease, it's a disaster. High school's going well, but I still worry about her missing school and her general health. I worry about colleges and her disease limiting the places she can go. Even though I have work flexibility, I worry about my job and missing more work for more appointments. MAS 825 seems to be working well and doing its job, and for that I am grateful. The question that I grapple with is this infusion every other week from now until the end of time? Is this it? Is this what her life looks like? Thank you.
Thank you very much. Very briefly, I would like to draw your attention to another clinical phenotype of refractory systemic JIA that I think is becoming more frequent as well. And I have no idea how to handle slides. Yeah, specifically, I'm referring to the patients with refractory systemic juvenile idiopathic arthritis with relapsing macrophage activation syndrome. And I would like to stress from the very beginning, a significant proportion of these patients have predominantly liver involvement. If you look at the literature on MAS in general, I would say about probably 5% of the patients with MAS, Francesca, confirm if I'm wrong, all right? But approximately 5% of patients with MAS in general would have this relapsing course, or some would call it smoldering MAS. And these patients appear to be certainly at risk for the lung disease that we just discussed, but also a large proportion of these patients have predominantly liver involvement. And that's a very perplexing group of patients. Clinically, the clinical phenotype is very distinctive. These patients typically have persistently elevated liver enzymes with laboratory features of subclinical MAS, but in general, they typically do not meet the full criteria for macrophage activation syndrome. The biopsy findings in this patient population are highly characteristic. We typically see sinusoidal, kind of a perisinusoidal inflammatory infiltrate that consists almost exclusively of histiocytes and T cells. And if you look at the T cells, they are predominantly CD8 cells. We see highly activated Kupffer cells. Many exhibit hemophagocytic activity. And if we perform immunostaining for cytokines, that approach clearly identifies CD8 positive T cells as a main source of interferon gamma production. And interestingly, many of these patients actually may have perfectly normal bone marrow biopsy. And the majority of these patients have highly increased serum levels of CXCL9, suggestive of high interferon gamma activity in the tissue. So that phenotype actually was described long ago in 2005 by Karin Wouters. Here we're looking at a liver biopsy from one of her patients. If you look at the panel on the left side, you see this massive perisinusoidal infiltration with mononuclear cells. And if you look at these cells at a higher level of magnification, you can see highly activated macrophages, Kupffer cells. Many of them are plump, many of them actually exhibit hemophagocytic activity, and they also secrete cytokines. Another prominent cell population in this lesion actually are CD8 cells, and they make quite a bit of interferon gamma. Just give you a general idea how bad this disease might be. Two recent patients from our clinic both had significantly chronically elevated liver enzymes. One patient did have features of subclinical MAS continuously. The other patient did not. And you can guess who is who. So if you look at the left side of this slide, you see this sort of massive periportal infiltration with activated histiocytes. And this is actually very, very different from what you see in another patient who had elevated liver enzymes but no signs of MAS. So I also would like to mention this paper that Fabrizio's group published a couple of years ago. They described 3 patients with this particular phenotype. They looked again at the histopathology of the lesions in the liver. They performed some gene expression profiling and picked up a very, very strong interferon gamma induced signature. So the question is how to handle these patients. The question is, it's a very difficult question. Certainly medications, what I hear from my colleagues and patients as well around the country, I think the medications that are typically used in this patient population include JAK inhibitors, cyclosporin A, MMF. Paul mentioned etoposide. But the problem is that when I talk to my hepatology colleagues in Cincinnati, they say, well, whatever you do, try to avoid using hepatotoxic medications. And all of these medications are, particularly your favorite etoposide. So there is an increasing interest in using emapalumab in this patient population. I'm aware of quite a few patients in the country that are treated with emapalumab continuously. Emapalumab I think is a great drug, but it has been developed to be used acutely for acute episodes of MAS. I'm a little bit worried about the chronic use of this drug in our patient population. We'll see what happens, but we do know what happens to other otherwise healthy people who develop neutralizing anti-interferon gamma antibodies. And they do develop significant infectious complications, including tuberculosis. So again, lots of questions. We have no idea how to handle at the moment this disease. And it's very difficult to enroll these patients in any clinical studies. They do not usually fully meet the criteria for macrophage activation syndrome. Because of that, they are not eligible for the clinical trials, specifically in MAS. Most of these patients have predominantly systemic features and lack arthritis. For that reason, they do not meet the diagnostic criteria for systemic juvenile idiopathic arthritis. That makes them ineligible for various SJIA trials. And due to the absence of genetic diagnosis, they cannot be enrolled in the ongoing trials of various inflammosopathies. The other major issue with this patient population is that we actually don't know how to measure the outcome in this patient population. As you know, the outcome measures for the systemic component of the disease are not very well defined. Specifically for this population, some suggest that we could still modify the standard ACR-GIA measures. I think Fabrizio will talk about that. Some suggest that actually we could probably use the autoinflammatory disease activity index, but again, it needs to be tailored for this specific population. And the other major issue is that all of these kids are on numerous background medications, and we have no idea how to handle those medications if we enroll them in any kind of a trial, because most trials do require withdrawal with variable washout periods. So I would like just to draw your attention to this specific group of patients and kind of think how we could approach and develop clinical studies that would cover this specific clinical phenotype. Thank you.